Thank you, Patrick. I had to wait for that recording in progress note. And appreciate the opportunity to speak with all of you today. Really appreciate Patrick's introduction there. I'll just jump in. So for all of us, the COVID pandemic has affected us in many ways and in many aspects of our lives as well. We've seen a dramatic shift in how medicine is being delivered, not only during the pandemic, but that has remained and believe it will remain into the future. It's becoming a new normal, one of us like none of us have ever seen in the past. And so our goal today is to provide actionable information, ideas around ways to improve payer-provider collaboration during this time of great uncertainty. When we have communities and patients and members with increasing needs, health plans and providers, along with our entire healthcare system, really continue to be stressed in ways that we have not historically seen. As we look at the Medicaid market, a lot of these statistics are from Kaiser Family Foundation, showing that we see an expected increase of 7.7 to 8.2 million enrollees, beneficiaries in 2021, almost a 12% increase. And the thought process is that this will continue to grow to 90 to 100 million beneficiaries through fiscal year 2022. Unemployment is directly correlated with this. And as we've seen and through the pandemic, there's a spike in unemployment. Folks are starting to get back to work, but the increase in Medicaid enrollment, the demand for services, the demand by patients that have been unseen for quite a while will continue as we come out of this historical pandemic event. Managed Medicaid is increasing as well, predicted to move from 78% to 83%, and state budget shortfalls are affecting this as well. In fiscal year 2021, they're estimated to reach as much as $290 billion. And so that is affecting the ability to fund these managed Medicaid programs, and that movement from state funded to managed Medicaid will continue to push. And from an economic recovery standpoint, we still are seeing growth in the uninsured population as well. Over the past 50 years, it's taken approximately 58 months from recession recovery to full recovery. And we anticipate that while we're enjoying this kind of newfound maskless freedom and travel, and as we sort of return to normal, the new normal is upon us, and these economic stresses will likely continue for many, many months. As Patrick said, I'm Bill Kais. I'm the Chief Growth Officer at I2I, and our mission at I2I is to bring technology solutions to community health centers, health plans, and other providers to really improve health of complex and underserved populations. Our goal is to help care coordination, improve quality scores, close care gaps, and increase revenue. So objectives for today are to understand how to bridge the gap for quality improvement and alignment between health plans and providers through bidirectional clinical data integration. This improves communication and collaboration, as we'll talk about throughout the presentation. There are significant benefits to both health plans and providers, including improved quality scores, reduced chart chasing, increased revenue, and improved care gap closure as well. Also want to try to outline the quantitative and qualitative benefits that can accrue to both partners through this clinical data exchange. And I will emphasize several times the importance of bidirectional integration to improve the collaboration and have value to both parties that will accrue through this bidirectional integration. So Some of the challenges related to payer-provider collaboration that we've seen in the marketplace, managing member health. Payers typically lack that rich clinical data directly from the EHR. We have some statistics in just a second about that. But it's a challenge. It's a challenge relying only on claims data to close care gaps and to improve HEDIS scores. Improving the community health and reducing cost of care are all huge challenges from a member management standpoint. From the fact that COVID-19 has really highlighted and put a bright light on pent-up medical needs, unemployment is high, and the ability to manage new and unseen patients between the health plan and the provider is a key challenge as well. Being able to identify and match health plan members with provider patient panels to identify the members that have not been seen, get them into the clinic so we can not only improve quality across the community, but there's a revenue impact as well at the provider level. Improving quality program performance, HEDIS performance, that lack of clinical data at the patient level really can hinder, in many cases, the data numerators, denominators, and that has an effect and is a challenge when you only are dealing with somewhat delayed claims data. And so that open gateway to the EHR is many times a challenge for provider collaboration and clinical assessment at the patient level. And lastly, streamlining chart reviews. It is a difficult process both on the payer side and the provider side, very costly process, and reducing chart chases and improving efficiency of that chart review process on both sides can be a big challenge as well. And that will require standard supplemental data, and we'll talk a bit about that as well. So data from Gartner back in January of this year showed that while 48% of health plans are ingesting EHR data from provider systems, a small percentage, 14% or so, are receiving data in an exchange standard, only 14% from more than 5% of their in-network providers. So it's kind of catch as catch can, not a lot of standards. Data cleanliness and integrity can be an issue. And as we talk about ingesting clinical data from providers, we cannot overstate the importance of ingesting data that meets supplemental data standards. It's incredibly important to be able to reduce audits and have extremely clean data that comes into your organization prior to running it through your HEDIS engines or using it for other purposes at the health plan. So how do we build a case for this? Given the challenges and both technology challenges, challenges with collaborating, we do need to build a case for clinical data integration. The fact is that we need to meet the most pressing needs and improve outcomes across communities that we serve, which will require a collaborative effort. These are underserved communities. These are, as you know, safety net providers in most cases, and that goal of improving health outcomes across the community needs to be number one. Clinical data exchange allows health plans to capture comprehensive and very rich clinical data through EHR integration and drives significant benefits to both parties, actually all parties, the provider, the health plan, and the patient member themselves. It is becoming more common as payers and providers work to improve the clinical quality measures and collaboratively, easy for me to say, close care gaps, reduce chart chasing, and coordinate care across these communities. It is becoming much more common to share data back and forth between MCOs and providers. These partnerships are evolving, and as we move towards value-based care and risk-sharing arrangements, this will drive additional needs for collaboration and data sharing. The significant return on investment can be accrued, which will support funding for these initiatives, and there are a number of ways to go about it, which we'll talk about. And as I said earlier, providing value to the provider side of the equation definitely creates winning partnerships. And so having a case for integration that is one-sided and the payer has benefits by ingesting the clinical data, but doesn't provide any value to that provider is definitely something that we need to think about, and we'll talk about. And overall, building data exchange solutions that facilitate communication will bridge the gap for provider trust, care coordination, and alignment between the health plan, the member, and the provider of care. So let's talk about the clinical data integration value chain. It's composed of several steps with distinct processes, some of which can be accomplished cheaper and faster by third parties. And it can be a complex process. It's not plug and play in most cases, and payers typically struggle with the variety of different EHRs. And if you've seen one EHR from eClinicalWorks or Athena, you've seen one instance of that EHR. It is a very different the way it's utilized and the coding, and so normalization is very, very important. And so as we look at everything from gaining provider consent to share data and exchange data, which is a contractual process, integrating the data, integrating with that EHR, doing any types of mapping, acquiring the data into a data warehouse, and then normalizing that data. Many of those steps can in fact be accomplished by data providers or data aggregators that have already built these integration platforms and data warehouses with providers across the country. We then deploy the data and apply it at the payer level, whether that's driving it through your HEDIS engine or risk adjustment or care coordination, care management, et cetera, et cetera. So several roadblocks. We'll talk a bit about roadblocks here. Number one is kind of a common approach to ingesting and using the data. As an MCO health plan, one of the roadblocks is internally building that common approach. How are you going to format the data? What should it look like? What data elements do you need? And what are you going to do with it when you get it? We recommend a standard approach in order to be able to scale and work with vendors that will provide data standards. We talked a bit about the data quality and usability, and having that standard supplemental data that is not manipulated as it comes out of the EHR, so it will pass your PSV audits. Identifying technology partners and data aggregators, data providers that have relationships with multiple providers across the country can create a single point of integration, which can have added benefits. So instead of going to 100 different EHRs, you're going to a data aggregator or a single integration point for multiple providers around the country. So take a look at that. That many times is a huge roadblock, doing interface after interface after interface, even though you may have a relationship with one particular EHR vendor. As I mentioned earlier, every instance can be very different. Provider adoption is critical. And so when we talk about value on both sides of the equation, it is important to provide something of value. And we feel strongly that providing usable data that feeds into a population health management program or some other program at the provider side that's usable in their clinical workflows is valuable to that provider and will help improve adoption and collaboration. Normalization is important as we talk about link codes and other various coding structures that are out there in the various EHRs. That's many times can be a roadblock. And just the lack of hard ROI and budget. It is difficult to measure sometimes if you haven't in the past acquired clinical data. It is hard to measure what is the uptick that we can expect in our HEDIS measures based on that rich clinical data versus using the claims data through our HEDIS engine. So some of those roadblocks are big. And as we talk about the ROI, here's what we've found in our customers. And number one is really that uplift that I talked about just a second ago. Uplift from baseline HEDIS measures using rich clinical data, having all of the data on immunizations and all of the information that you need for the clinical events, all of the lab data, all of the vital signs and things that are very critical to measure quality scores are available in that clinical data feed. Chart acquisition and chart chases, chart acquisition costs can be reduced by at least 50%. It is very expensive for third parties or for the payers and for the providers to extract those records manually. There's tons of portals running around and access to EHRs, et cetera. Having that clinical data can greatly reduce that chart acquisition cost. Better data and evidence for risk adjustment. Just again, more rich clinical data, better data for risk adjustment. Understanding social determinants. We find that most of our payer customers now are working very collaboratively on programs to reduce transportation issues, food issues, and those types of things. And so as the providers are tracking those social determinants of health and those measures, those can be ingested as well in that clinical data file. Improving care gap closure to improve the overall quality of care is obviously a huge goal and has a significant ROI. Engaging unseen and at-risk patient populations as well would increase revenue and helps that numerator denominator as well from a quality measure standpoint, being able to get the unseen patients that are attributed to a particular provider into that clinic and get them seen, help them close the care gaps and improve those quality scores. And then really, being able to improve the engagement at the patient level with that clinical data to more accurately assess member risk. So what does this look like? From a framework standpoint, it looks fairly simple, but there's a lot of steps, as we talked about a little bit earlier. The idea is to acquire the data and extract the EHR specific data, both structured and unstructured data. We use tools, integration tools like FHIR, HL7, et cetera. Aggregating that data into a single unified patient record, normalizing that data, and then providing the data either CCDA or flat file. Right now, we're typically providing this data in flat file. As NCQA comes out with the data aggregator validation measures or certification, we might be moving to CCDA. There are different reasons to use a CCDA versus a flat file. And so both can be provided to deploy within the MCO to close care gaps, quality measure improvement, care coordination, utilization management, risk adjustment, as we've talked about. This is what it looks like when we talk about this value on both sides of the equation. And we talk about the bidirectional integration. In our model, I2I has about 300 FQHC and rural hospital, critical access hospital providers around the country. And they use our data warehouse, and we ingest the EHR and practice management data, operational data, and clinical data from their EHR into our data warehouse. That is fed into our population health management tool, which we call Tracks. The health plan sends the member file. Attributed member files are received, integrated into the population health management tool. We match the membership and extract directly only those members from the EHR. We then load that attribution file, and they're defined as seen versus unseen for member outreach activities, patient outreach activities in the population health management tool to try to reduce unseen patients. Clinical data then is sent to the MCO directly from the EHR after that patient matching occurs. The visit information, labs, immunizations, problem lists, SDOH data. Then the health plan turns around and can load care gaps, payer care gaps from the claims data for insight and closure in the population health management tool as well. And so again, this interactive process happens monthly, and it is bidirectional, which provides significant value to the provider and improves the collaboration greatly. There's definitely value on both sides with this bidirectional integration. A little bit of detail, I won't get into this in gory detail, but the encounter and visit information, labs, problem lists, immunizations, et cetera, are sent as standard supplemental data. From an eye-to-eye perspective, our customers have never failed a PSV audit. NCQA likes our data. It's very clean, and we've been in business for 20 years and have been doing this for in a Medicaid space for a long, long time, and are very adept at doing this. And the process is very simple, as I just described. The plan sends the member attribution files, can be a full enrollment file, historical claims file, or attribution list. We do the matching. We will extract 2 to 3 years of historical data as well and provide that so you can look at trending, and that information is provided to you as often as the health plan would want it. Data is dropped to a folder that's owned by the plan, and the attribution files and care gap files are pushed to the provider for use in the population health tool. And so to kind of summarize the value a little bit here, the value to the health plan, as we talked about, is that the file, first and foremost, meets the criteria for standard supplemental data. Many times we hear that the EHR direct data it can be limited, perhaps only visit summaries, not a full clinical record. And so we want to make sure that our data meets the needs of the health plan and the goals that our health plan customers have for use of that data and deployment of that data into their systems at the health plan level. We've seen improved HEDIS scores upticks compared to just plain claims data using that robust clinical data. Definitely reduced costs associated with chart chases, et cetera. I have a case study here in just a second. But again, on the right side, the value to the provider, which should not be minimized. To improve adoption, it is important to focus on the value of this collaboration. They have a ton of administrative burden with copying medical records, trying to track down charts, et cetera. And so the reduction there can be significant. The attribution files will generate revenue for these unseen patients that are then seen in the clinic, helps with proactive care gap closure, as we've talked about, and really strengthens those community alliances with the managed care organizations. Here's a quick case study. This was a national MCO operating in Maryland. Overall enrollment for the Medicaid plan was 277,000 lives. And we looked at 3 provider organizations, and that panel was 37,000 members for this particular MCO. They had the traditional medical chart collection process. It was costly, about $25 per chart. Gave them a one-time snapshot, really limiting the use outside of that one-time HEDIS reporting at that period of time. Providers typically didn't want to provide that access directly to the health plan through a portal. And so it became very resource intensive on both sides to do those chart chases and find those patient records. The EHR extracts from providers at this particular MCO had trouble passing NCQA audit. And so they had trouble using the clinical data that they were getting in lieu of the chart. And they wanted to really kind of streamline the process. And so we implemented our clinical data integration solution, and on a recurring basis, provided the clinical data to this payer on a monthly basis. They got great adoption. Maryland now has, for this MCO, continues to expand to upwards of a dozen providers, and the results were significant. $350,000 a year in charge chase cost avoidance, over $1 per member per month Medicaid risk adjustment impact using the clinical data, and across the board, almost 100% of their HEDIS scores were improved, with the top four, as you can see there on the right: blood pressure, BMI assessment, BMI percentile documentation, and Hep B immunizations, childhood immunizations. So some great results from this particular collaborative effort in Maryland. As we look at the progression and the technology needs for successful payer-provider collaboration, really it kind of starts with this data exchange. And so when I2I started this, we were very data exchange driven. We had our clinical data ingestion. We'd send it to the payers, and our customers said, well, geez, wouldn't it be great if we really had the ability to integrate more information into our population health to make this truly bidirectional and collaborative? And so we started to synchronize data with the population health management workflow and populate those attribution files, claims care gaps into the workflow at the provider to engage unseen members, close care gaps, and improve HEDIS and other quality outcomes, frankly, across their patient base, their member base. The next step, really, as we get to care and quality management driven technologies, is to have a single platform where the payer and the provider are looking at the same data. They have true clinical integration. They're looking at the same chart, engaging the provider in care management collaboratively, driving pay for performance programs, looking at HEDIS and many other quality program maximization to create those true community alliances. So we're all getting there, and it's growing very, very quickly. And our goal as a company is to provide the tools across the continuum here for technology tools to help improve quality of care in the communities that you serve. So let's wrap it up real quick. As we've talked about, alignment, collaboration through bidirectional clinical data integration will improve communication between providers and payers and will drive significant benefits. We've seen that over and over again in many, many markets across the country. There are challenges, but we would suggest that you pick partners who have proven methods, meet industry data standards. As we talked about, data aggregators, data providers many times have relationships with multiple providers, and it can be a little more plug and play than having to do hundreds of interfaces in order to get clinical data out of a single EHR. And it's important that value accrues to both sides of the equation through improved quality of care, care gap closure, reducing chart chasing, and increasing revenue for both the provider and the payer, and then ultimately the goal of improving quality of care within the member, within the community. So with that, I will say thanks for all you do. We're all in this to help serve communities, underserved communities, provide high quality care, improve quality care to underserved members, patients across the country. So stay healthy, and thank you for that. And with that, I will move to some of the questions. I did see some come through, so let me bring up these Q&A boxes if I can. Let's see. So a couple of, is I2I and HIE? Nope, we are not. I2I is a population health vendor, and in order to service our customers, we develop data warehouse, right? And the data warehouse would include information from EHR, practice management, HIE, dental solutions, behavioral health solutions. And from that, we then serve the data up, if you will, at the provider level to the analytics solutions, the population health management solutions, and also can provide that raw clinical data to payers. So our typical customer is FQHCs, critical access and rural hospitals, independent practices, very much focused on Medicaid and underserved communities. Let's look at the chat box. Let's see. There are questions in a couple of different areas here.
Bill, we actually have one attendee who has raised his hand, Neil Solomon. If it's okay with you, I'm going to unmute Neil for his question.
You bet.
Okay. Neil, you have been unmuted. Ask
Wow,
away.
I've been unmuted. Can you hear me?
Yeah, we can.
Yes.
All right, great. Thank you. I accidentally clicked raise hand when I was going to do Q&A, but it's much better to do it verbally, so I will. So I represent a provider organization that specifically services high risk, high cost members. And we've built some sort of homegrown dashboards and population health tools, but they're nothing like what IHI has built over more than 20 years. But in the markets that we serve, how would we go about using your tools? I mean, you are obviously doing this from the perspective of health plans because it's MHPA. So I'm kind of an interloper here in some ways, although, you know, we love MHPA. We work with a lot of their participating plans. But how would we, as a provider, use your services unless the plan or the plans that we work with in a given market already are on board?
Actually, it's the other way around. We really start with the provider. And so our core tool, our population health management tool, which is called TRACS, is implemented in FQHCs, critical access practices such as yours across the country. We have about 300 customers that are providers of care that use our practice management tool, and that our population health management tool. The tool sits on top of the EHR practice management data that is ingested. And so our first step is really to integrate. So step one is to integrate with the EHR data at the provider to build our data warehouse. And the tool, our population health management tool, TRACS, is used by providers to manage quality interactively. We have 300 quality measures or more. We are HEDIS certified. And so it's a real-time quality tracking tool. It is a population health management tool to help manage chronic conditions and do patient engagement, patient outreach. So for example, you have a patient panel that is created based on those patients who have A1C greater than 9 that haven't had an appointment in the past 6 months. We want to text them or we want to email them, get them in to the practice. And so really population health management. From there, we evolved to realizing that the MCOs wanted to collaborate and wanted this data. And so that business model is probably 3 years old, 4 years old, and came out of, you know, really this collaboration need and the need for clinical data and clinical ingestion, if that makes sense.
Yeah, I just clarify my question, because we're an unusual provider in that we're brought in as an extra layer of care on top of the existing system for patients who are particularly complicated, hard to find, homebound, that kind of thing. And so for us, we're highly dependent upon getting access to data from other sources to know whether someone is actually due or to be able to refer them and communicate with others. And so we are highly dependent upon the rest of the delivery system and the health plan to help us get that data. So in markets where there's a data exchange, we sometimes have more success. Otherwise, we're highly dependent on each of the actors sort of sharing with us. Got it. That's why I was wondering if you could help us. Maybe it's worth taking offline.
Be happy to talk more about it now.
Okay, thanks.
Thank you. Other questions? We had a couple questions about, one question about kind of the pricing model. Would love to take that offline, if that's okay. I know the presentation deck and the recording will be available afterwards. And Patrick, unless you see some, I don't see any other questions in the chat box or the Q&A box at this point.
Yep, absolutely. And as a reminder, because we did have a few people ask, as you said, Bill, you had an email with the slides and the YouTube video of this recording. So yeah, I guess with that, I'll go ahead and close it out. I want to thank Bill. That was a very informative presentation. Everyone will be able to follow up with him if you have questions later on, of course, with I2I, all the great work they're doing. I want to thank them again for being such a great supporter of MHPA and our member health plans. They're longtime partners and do great work. And so with that, again, thank you, Bill. Thank you, everyone else. Have a great afternoon, and please be on the lookout for more MHPA Webinar Wednesday webinars.
Thanks, everyone.